Welcome to Boombostic Health, where we challenge the business of healthcare and explore bold ideas that drive meaningful change. Each week, we bring you candid conversations with top experts, innovators, and leaders, exploring the latest trends and technologies shaping the future of healthcare. Join us and be part of the conversation in transforming healthcare. Hey everyone, Bradley Bostic here. Welcome to the next episode of Boombostic Health. We're on episode 18. And here today, I've got Sherri Ozawa, who, in full disclosure, we work together at HC1, where I'm CEO. And also, though, she is actually at a global level, a thought leader and expert on patient blood management, which, as we're unpacking in this series of podcasts here, is a massive component that has been, up to this point, not really optimized in many cases. In some cases it is. But just, quickly on Sherri's background. So she is currently the Director of Clinical Operations and Delivery for Comprehensive Patient Blood Management at HC1. Also a founding member and past president of the Society for the Advancement of Patient Blood Management. And most interestingly, I think, she has all of this expertise that has been built over a couple of decades that also includes what you refer to as bloodless medicine. So that's a function of the environment where HIV and AIDS epidemic were happening. Transfusions were really difficult in those times. So she learned a lot through that. And we're super lucky to have Sherri here today. Luckily, she's not off in Italy speaking on behalf of one of these major organizations, or Malaysia, as you recently were with the World Health Organization. Sherri's actually one of only two representatives from the United States on the World Health Organization's working group on patient blood management. And she's the only nurse representative. Is that correct? Yeah.
Sure. Thank you.
And I have to also give the promo that the other person from the United States also works with us at HC1.
Indeed, Dr. Gross.
Dr. Gross. So we have a corner on the market of the World Health Organization patient blood management, which is something we're really proud of. So thanks for being here, Sherri. Really appreciate you taking the time.
Thank you, Brad. So great to be here. I'm so excited to talk about this subject.
Cool. So with that said, you could be doing a lot of things with your career, and you've been invested here. What inspired you to get into the patient blood management world and just to healthcare in general?
Yeah, thank you for the opportunity to talk about it. And I will go into ancient history because I've been in for a few decades, but started my career really first actually as a musician, made a shift when had to make a living into healthcare.
A musician. And what's your, tell me about that. As a musician, what is your specialty?
I'm a cellist, actually, a classical cellist.
That's amazing.
Yeah,
so did you perform?
I did. I performed. My undergraduate was in music therapy and played professionally. Not a superstar, but enough to make a few bucks, but, tough. I wish it were different, but the arts is a hard place to make a living. So
do you still play?
I do still play. Yeah, we have some really great, I live in northern New Jersey, right near New York City, so some great community orchestras. And interestingly, subject for a different day, but lots of medical people, lots of pieces of the brain, I think, lots of physicians and nurses actually in music as well. So
that makes sense. Well, you'll have to give us a concert sometime. That'd be fun.
I'll bring earplugs too.
Oh, I'm sure you're fantastic. Okay, sorry to interrupt your flow professionally, but just was curious to hear about that. So carry on.
Thank you. So I made a bit of a career change into nursing, kind of aligned with the music therapy background. And I was, I entered nursing at a very interesting time in history. During my student nurse years was really the height, unfortunately, of the HIV crisis. And now, thank goodness, right? Because of lots of great work, we have lots of therapies that can help patients. At that time, in the beginning, there wasn't a lot. So it was a really tough.
Nothing. It was a death sentence. I'll never forget the Magic Johnson, special that he got onto network television back when that was the main way that you got media. And shared what had happened. And at that time, you thought, well, probably he wouldn't be with us for very
Yeah.
long. So thankfully, as
Yeah.
you said, due to a lot
Absolutely.
of breakthroughs, that
Sure.
he is here. But
For sure. For sure. But in those early days, right, we thought a lot differently about the way we were delivering care. And although there was lots of means of transmission of that virus, one of them, as we know, was through blood transfusions and blood components. And as a result, right, there was really a very interesting pause all around the world on the use of blood and really a minimization because we were not sure of the safety. Now, like that has changed and we're not living in the past, but we did learn from that period of time is that people didn't stop getting sick, people didn't stop having babies, people didn't stop having car accidents, yet somehow we managed to manage these patients with much less and many times no transfusion because it just essentially wasn't available. And in many parts of the world, that's normal practice. There's parts of the world where it's just not there, right? Even if people were willing to accept it and it could be, it just doesn't exist. So you referred earlier to that term bloodless. That's kind of, the origin of that. In addition, there are patients for whom blood is not an option because they don't want to accept it, right? And it was an era of also really recognizing that people, you and I, we have autonomy about what happens to our bodies. So if somebody doesn't want it, they shouldn't have it. And early on in my career, then in nursing, and then as a critical care nurse, what we started to see was these patients who we thought, well, we don't have blood. Traditionally, we transfuse this kind of surgery or this kind of illness. These patients, boy, the outcomes are going to be terrible because we don't have the blood to use. In reality, a lot of times they did just as well and even better than they did when we were traditionally sort of transfusing them. So that made us think there's a whole lot we probably don't know about what we think we've been doing with transfusion. This is an area of science that we actually need to build.
So an unexpected consequence of the bloodless phase was you started to actually see what we thought was the standard of care, or should be the standard of care, was we were over transfusing, it sounds like, potentially.
Yeah. And, we don't have, again, time to talk about tons of history, but really, when you look at the way from a historical, and there's a big economic element to this too, the way that blood entered into our medical system, it did not take the traditional route that the things that we put in ourselves or in our patients or on our patients do. We have some concept of regulatory action through, in the United States, the FDA. Other countries have their vehicles for safety and efficacy, right? And in theory, whatever sip you just took or whatever pill I just took this morning, somebody has tested that to make sure that it's a liqueur. Yeah, okay, good.
It's a guava Sao Paulo. It's
Nice.
naturally essenced.
Well,
How's that for a marketing
nice,
term?
nice
Oh,
little
it's
plug for the.
disappearing. It's disappearing with my virtual background. But yeah.
You'll
Anyway,
see. All
yes,
right, we'll see what
somebody tested that to see what the contents
Right.
were so that it wasn't
Exactly.
harmful.
Exactly. And then if we take it a step further, right beyond the sparkling water into a medication, somebody has said this medication for your high blood pressure or my diabetes or whatever it is going to do more good than harm, right? Everything has side effects, but if the benefit outweighs the risk and patients are informed, we make the choice and we do it, right? Blood did not take that pathway. It never actually went to any regulatory agency to prove safety or efficacy. It entered the medical system during the world wars, and that is not in any way to take away from amazing work, right, that people have done scientifically in the military, at the front line. And the goal of PBM is not to, patient blood management, we'll talk about in a minute, is not to say blood should never exist for transfusion, it should go away. It's just really to say we didn't really know what we were doing. And as a result, we were overdoing something that we had never really actually tested to be safe and effective.
Well, and I suppose there are multiple different reasons to transfuse. In some cases, you've lost a lot of blood, like in that example of an injury in the
Sure.
battlefield.
Sure.
And in other cases, though, somebody might have a low level of iron in their blood, for example, like with anemia. Is that fair?
Exactly.
And sometimes that's people transfuse for that. But I think if I am understanding your perspective correctly, your view is that we should be exploring all different options before transfusing, just like you explore all different options before you do an organ transplant.
Exactly, Brad. And that's, you really hit the heart of it. is that, right? If we start to have a patient or ourselves have some failure in an organ system, we know probably friends or family that have some level of heart failure or kidney failure, right? Too common, maybe. But what happens with the clinicians who take care of those patients? They don't start to have heart failure and we say, okay, let's transplant immediately because, right, those organs are not readily available. And there's a bunch of other things that we need to do first, right? So there may be medication changes. We may tell people how to have a healthy lifestyle, control stress, control blood pressure, all these different things. And then as a last resort, if it's available, right, and if the patient's willing to accept it and all the things line up, we may transplant that organ. So if we look at blood, it's sort of almost overly simplistic, but if we think of blood not like an IV fluid or like a medicine or some substance, we think of it as the body's liquid organ. The first thing we don't jump to is not to replace it. We might eventually get to that point, but we try to do all the other things to essentially keep it inside the patient and keep it healthy, or inside us and keep it as healthy as possible in the simplest form. And then we mitigate so many risk factors. So for some patients, eventually, that big battlefield injury, that big cancer diagnosis, transfusion may be indicated. But is that the last thing we reach for and try everything else first to optimize what's already in this patient, this amazing untapped resource?
So if I think about like skin as an organ and you want to protect your skin, you put on sunscreen.
Exactly.
Or your kidneys or your liver, other organs where they're helping to get impurities out of your blood. And so in that case, you've got certain dietary things you can do. What's the equivalent to sunscreen with skin to what your blood is? How should our viewers, listeners think about how you take care of your blood? How do you make it better?
Yeah, and it sounds like even we don't really think about it, right? The way you just expressed it, we don't really go to the doctor. A person might go to the doc and say, like, to the dermatologist, give me the once over, I'll take a look at my skin. Or we'll go to the doc and say, how's my heart doing, doc, right? We don't almost ever ask that about blood, but why wouldn't we? So
and nobody ever shows up and says, man, my blood is in tip-top condition, right? It's like everything else, but not your blood.
But if you think about it, we actually use the blood to interrogate every other organ, right? So no other organ in the body, the skin, the heart, the kidneys can survive without the blood. And it tells us what's happening with every organ. So in a sense, I would argue, right, like it's maybe the supreme organ of all of them. But to your point, right, when we are responsible and we take responsibility, like our skin, like our heart, for our own health, we should be informed as consumers, right? What is a normal blood count, for example, just with hemoglobin, right? And a lot of people don't know that. They may now, right, know what a normal blood pressure is, or that they should look for whatever in a mole, right? Shouldn't look like that, or, something's wrong. So we should, at the very least, know what our normal blood counts are. And when they're low, and we can talk, and in other podcasts, you're talking about anemia, but anemia or a low blood count has almost been normalized, particularly for women in our society, where like there's millions and millions, a third of the world's population walking around with a fixable problem that we just have normalized. So like it's about, in part, right, advocacy for ourselves, for our families, for our patients to say, just like my heart, just like my skin, how do I address the health of my blood? And that there's nutritional elements to that, right? There's testing where things we can look and optimize. So, I mean, there's a lot of things, and we get deep down a clinical hole, but we should put it at the top of the list, because without our blood being healthy, nothing else is healthy either.
Yeah, it's fascinating. But did you say in there, what is a thing you can do, or where do you go? Is there a place you can go read about how to make your blood healthy? What's, like, how do we do it?
Yeah, I mean, sure. So at the very least, right, I think first it's information. So what are normal numbers? There's, like anything else, there's a lot of junk online. There's a lot of very reputable sources about what is considered normal. Certainly speak to your healthcare provider, and bring up the topic, as we might other parts of our, of our organ systems in our body. But nutrition is a huge piece of it. It's amazing that, like, back to the anemia topic, even in places like the United States or other developed nations where in theory we have access to really good nutrition, there's millions and millions and billions of people walking around iron deficient. And eventually they'll become anemic. There's people who are not even anemic yet and iron deficient. So really nutrition is a huge piece of it. And then another piece of it is that there are millions and millions of people, particularly a higher rate of non-detection of actually bleeding disorders in women. A lot of people have them. Everybody thinks, well, there's not that many hemophiliacs around. There are other types of bleeding disorders. Significant the percent of the population, which sort of these lower level bleeding disorders, but finding them early, being aware of your own body. When you have surgeries, when you lose teeth, some of these things, sometimes they show up like that, and they may not be normalized. So it's really communicating, finding that good healthcare provider, communicating proactively with them, and spending some time talking about the health of your blood like you
Right.
do everything else.
So we're talking about lab testing that helps to measure these levels. And then I'm a believer in functional medicine, which is a dimension of this that some people don't buy into, but for me, it seems like it's been helpful.
Absolutely.
So the reality historically was there's a lot of change in terms of the perspective on what's the best practices. And then you move into this awakening period where people realize what they should be doing, but then how do you do it? And I think technology is starting to play an increasing role in this. And clearly you've got a part in that. Would love to hear how you see things evolving, and how can we get to a future where every provider around the world is optimizing the way blood is managed, kept healthy, and ultimately transfused if needed.
Yeah, no, it's an important point. And to your point, technology plays a crucial role in this in many ways. But I'll focus for a moment on the data aspects of technology and how we can use that. I think, to go back to what we were saying a second ago, transfusion became this default position to treat anemia and bleeding, even without good data, right? Like we can even see it in our TV shows. We don't even know what's wrong with the patient, but it's exciting. They had an accident. They're in the ER, and we're hanging blood before we even know what's going on, right? So that's a little dramatic, but it really has affected the culture around the way that blood has been used, and as a result, clinicians often have a very different perception of what they're actually doing with blood and transfusion and anemia than what they actually are doing, and that's where data and technology really helps us. And what we find over and over again around the world, and what published literature says, is there's a big difference between where physicians think they make decisions around blood health, and transfusion, and the realities. And so having technology that provides that reliable, actionable data to health systems, to clinicians, is incredibly eye-opening. Of course, supportive of the education, right? The science has to be there to say we need to do things differently. We need to think differently. Transfusion isn't just the easy answer because it's available. It's expensive. It's risky, all these other things. But here's the data that actually drives the reality of what practice is and where we need to change to.
So when you were at the World Health Organization event in Malaysia, what did you speak about there? What is that audience interested in?
Yeah. So, again, there are places in the world where blood is just not an option, or there's no safe blood available, and they know it, right? I've spoken in Malaysia is not fortunately in one of those places, but there are large parts of sub-Saharan Africa where I've sat in conferences, and it will be like nothing, where a speaker will say, 50% of the blood supply is HIV positive from the blood bank, and we use it because that's all we've got, or we don't use it because we're nervous. And you think, did I just hear that?
Oh, this is in this day and age in 2025, that's happening, where people are knowingly transfusing blood that's contaminated.
Not because they're bad people, but they'll use what's available, or they'll try not to at all, right? So, that wasn't exactly, fortunately, the issue with Malaysia. But what is of interest really to the WHO is that we, again, had this default position, cultural approach to immediately replacing, if it's available, this body's liquid organ. Yet we have not been good stewards of the blood that's in the patient. We've not gotten the right data around it. We've not measured it right. We've not paid attention to it, and we've not kept it healthy. So that was really a large focus of what we talk about at a lot of these conferences. And the World Health Organization Patient Blood Management Policy Brief, which is available online. There's an implementation guide about to be released by the WHO, which actually is going to tell countries what to do, not just this is important, but how do I actually do something about this? But the point being, there's this incredible untapped resource in our own bodies and the billions of people around the world. And And instead of constantly turning to the donor pool, saying like, how do we get more people to donate blood? And that's not to vilify the generous people who donate, right? These are kind, good-hearted people, but we will never be able to match up until we look at the supply side, the demand side. And how do we reduce the demand? By keeping the blood inside the patient and keeping it healthy, right? It's very simple. So, but that's really the focus of the World Health Organization working group. The time I spent in Malaysia and these other countries is we've overlooked this resource, spent our time on the supply side, not on the demand side, because we've lacked good information. That's where we need to pay attention.
So the use of blood clearly has an impact on the patient in terms of their recovery and complications and potentially even mortality. The other side of that is we need some type of economics to support these programs. Why does it matter from a bottom line perspective?
Sure.
There's no margin, there's no mission, all the realities of the C-suite of a health system. I was just down in Indianapolis and drove past the new Indiana University Health building. It's a $5 billion, from what I've been told, development. So somehow they're must be focused on generating some type of money to pay for those sorts of things. Would love to hear about the economics of patient blood management for a health system. If I'm a CFO, why do I care about this?
Sure. Well, there's a couple sides to that, to the economics. And we say that, patient blood management is driven by 3 E's: the economics, the ethics, and the education around it. So to spend some time on the economic side, really, we can look at really just the transfusion process. Again, the PBM is not about transfusion, but if we look at transfusion as what has been the default position, and here in the United States, hospitals have to buy the blood, right, from the blood centers or from the American Red Cross. Different countries have different models, but we're here in the States, so we'll focus on that. It's one of the most expensive things that a hospital buys, certainly in almost all cases for a laboratory, their biggest bill, what they have to pay for. And again, that we're not here to say nobody should buy any more blood from the rec, right? There are patients for whom this is going to be indicated. But I was very fortunate to be part of really the seminal studies on the cost of transfusion. We published both red cells, we did red cells, platelets, and plasma. And what we found is that to transfuse a unit of red cells is about 3.5 to 4 times the cost of acquiring it. Now, it costs about $250 to buy a unit of red cells from the American Red Cross. That's just a general figure for the United States or a blood center. It costs upwards of $1,000 or $1,200 or even more dollars to transfuse that unit of blood, right? Because it's a liquid organ transplant. There's time for a lot of nursing time, consent time, testing time, because we want it to be safe. We do. But when we consider, Brad, that at least conservatively 50% of the time that we transfuse just red cells, we could talk about platelets and plasma endlessly, but just red cells, we didn't need to do it, right? It was either avoidable or completely not indicated. What does that equal, right? $1,000 or $1,200 or $1,300, hundreds and thousands of times over for a nation. What does it equal for just a health system?
Well, I also wonder, Sherri, is there the cost of the medical care following these events? Because as you said earlier, not only did you spend money on the blood product, but if there's an outcome that is negative, they end up being hospitalized longer. They end up having some other type of related causal illness, or, I'm not sure exactly what those are, but I know, like, for example, if you're prescribing people ineffectively, they end up in the hospital, and that ends up costing thousands of dollars. So who cares if you gave them a pill that was $50 less? You still, caused a huge amount of cost. Does blood relate to that too? And has that been studied at all? More of the medical costs related to the blood?
Yeah, and you're getting really to the heart of the economic issues. Again, I won't give away the age, but when I started in this field, there was really almost nothing in the literature about exactly what you described, really the outcomes piece of transfusion. And then we started to see, the one-to-one if a patient contracted HIV, that was a serious event. Fortunately, that happens very rarely. Much more commonly, though, right, is the sort of standard transfusion to a patient who had a bleeding problem, had an accident, was anemic. And what we learned after, really encouraging colleagues and publishing, now there's thousands of pieces of medical literature that actually was looking to see if we were really benefiting patients because we were doing this all the time. We must have been contributing to better outcomes. And exactly what you said is the case. What it showed that in the vast majority of cases, we may have fixed a number on a lab test, but we actually contributed to a poorer patient outcome. Longer lengths of stay in the hospital. You want to name the list, we could go all day. More cardiac complications, increase admission to the ICU, on and on and on. So we really wanted, and again, we're clinicians, right? We are in this business because we want to do the right thing for patients. So we thought we did the right thing, but because we really didn't have the evidence to back up the fact that we were helping patients, we learned that we were actually, in many cases, contributing to poor outcomes. That costs a lot, aside from just acquiring and giving the product. But if that seesaw doesn't tilt towards benefit, all we're giving is risk and cost, right?
So just the purchase of the blood is worthy of a CFO's attention because it's such a high cost item.
Absolutely.
But then if you also tie in even that bigger cost of ineffective or suboptimal utilization of the blood product, now we're getting into another layer of impact economically. And I will admit, and you see this too, that it's very difficult to determine where attribution should go for that downstream medical impact. But this seems like a pretty linked reality where you could study it over time and say, when blood was utilized in this way, things went a certain direction that was less cost, better outcome. These other decisions led to higher cost, worse outcomes, which is I think somewhat of the future of how healthcare gets improved is to begin connecting the dots. I think about the patient journey and that historically with lab information, with diagnostic information, it's point in time based on some acute issue, and there hasn't been a longitudinal or lifelong understanding of what was happening with that individual's health. And it sounds like in this case, you're really driving a value proposition that starts to connect those dots more as it relates to blood.
I think you're making a really good point. It really does connect. Patient blood management is a really nice fit with the patient journey because it starts right in the primary care space. It's the lifespan of the patient, right? Even from birth all the way through. And again, that blood tells us about what's happening completely with every other organ system, every level of health in that patient, but be able to personalize that information and get that data reliably, accurately, and then in a meaningful way to utilize it, right? Transfusion is only a piece of that. That's an intervention. Much better to personalize that care over the course of the lifespan to lead to better health and ultimately better outcomes and better quality of life too. We know that when we do the right thing for the patient's own blood, we don't just do the right thing economically into their outcomes. People feel better. They are more productive. They're better able to go to work, right? It affects the GDP of countries for blood health. So there's a lot to talk about here.
So where is this ultimately going? If you looked forward another decade, you've seen history and that helps inform what will happen in the future. Where are we with patient blood management in 10 years?
Yeah, I know it's exciting because I think we came a lot farther than we ever thought. So I think we have more work to do, and we are making progress again with the global recognition that we have this untapped resource. I kind of look at it a little bit, and this is not a political statement, but a little bit like green energy in the sense that there is still a place for traditional fossil fuels, etc. But there's a concept that is in some way a resource that will not last forever. So it doesn't go away, but it always has its challenges. What are other sources, and how can those things work together for the good of humanity, but also for the good of business, right? Those things can coexist. So as we look at patient blood management, we have this untapped resource of the patient's own blood, which we, with good information, with good data, with good, lifelong understanding through the patient journey, we can optimize that blood health. I think we can do that in the next 10 or 15 years, where this becomes a high priority, not just for you and me on a podcast, but for physicians, for hospitals, for ministries of health, for departments of health and human services, whatever it's called in a country, for entire nations. Because when we really look at the data, I wasn't joking when I said that, anemia and not having good blood health affects, we can actually have measured that in several countries, affects the GDP of nations, because it affects people's ability to be productive in society. And it's something that's actually easily treatable. We just have to do it. So I think the future of patient blood management is this recognition at a national and a global level that this has to be prioritized. And while transfusion may never go away, and we appreciate the kind people who donate, this is not about that. This is about optimizing a resource and improving a resource that already exists. And there's the ethical reason to do that. There's the evidence behind it, and there's the economic reason and the economic benefit at certainly a health system level, but a national and a global level too.
Well, it sounds like this is an area that you're really passionate about, clearly. And also it's an area that you've made a big impact on. And it seems as though, to me, you're just getting started in many respects. So really awesome to learn from you today on the Boombostic Health podcast, Sherri. And thank you for being such a key member of the team at HC1 as well. We'd love to have you again sometime in the future on the podcast, and really appreciate you being on.
Thank you so much, Brad. It's been great to be here.
So much. We'll see you soon.